Well, here we are. It's week 7, and this lecture is going to be regarding hematology and anemia. What I'm going to be going over first is blood transfusions. And then an indication for a blood transfusion, I think the most obvious would be an acute type of blood loss. If you had some sort of trauma or a AAA that had ruptured, something where you're losing a big amount of blood in a short amount of time. Or it could be a chronic type of blood loss, like if you have a chronic anemia to where you are slowly losing blood over time, and then you still need a transfusion to help replenish that. You do need different blood components in your blood. There is an oxygen carrying capacity that is necessary in your blood. This is what supplies all of our organs and keeps our body alive. Okay, so if you don't have the blood in your body, you obviously are not going to supply the oxygen to everywhere that you need. There are also platelets that are included and clotting factors. And this is very important also, so this will help us so if we do have some sort of injury, we do not bleed out. And then there is also a volume expansion. Plasma, which is a part of blood, helps increase the volume expansion in blood. There are different types of blood that you can order. Okay, so you will see different things ordered as you are doing your clinicals on the floor. One thing that we don't see very often, but it is whole blood. This is rarely available, and this has every component of the blood included in this. So this is your packed red blood cells, this is your platelets, this is your plasma. It is whole blood. We very rarely need to transfer something like this, and again, it is very rare, so I'm not even sure if the blood bank would have this readily available. If you do get a unit of whole blood, it is usually about 450 mLs as far as the volume of it. What I think you'll see commonly is your packed cells. Packed red blood cells are the most common, and it's about 250 to 300 mLs per unit. And that is down on the left lower picture here. If you look at it, you can see that is O, type O, and when you look at it closely, there will be a blood number that you need to verify. You need to make sure it's the correct blood, when it expires, and the blood number on there. And you need to verify this with your patient at the time. There is also platelets. And again, sometimes our body does not have enough clotting ability, so they may need to transfuse some platelets. And then we also give often fresh frozen plasma, also known as FFP. This again is for volume expansion, and it's usually like a bright yellow color or kind of clearish even. And again, this is a volume expander. So many times if we need to give volume, but they don't need the full components of the blood, we will hang FFP. So obviously how we would measure how much our blood is influenced our client is one, looking at them. But what do we do usually? We will draw labs, and then this is how we trend our clients to see if they are improving after a blood transfusion. There is an increase in your hemoglobin by 1 and your hematocrit by 3% after 1 unit transfused. So rule of thumb, we usually will go and transfuse somebody that has a hemoglobin less than 8. Okay, so if they're less than 8 and we're trying to get them up to 11 or 12, technically if you wanted to replenish the full amount, they may need 3 or 4 liters of blood. Okay, usually you'll see ordered 2 units of packed red blood cells, and then we will draw labs, and if they need more, they may transfuse more the next day. If you get a unit of platelets, it will raise your platelet count by 5 to 10,000 after 1 unit transferred or transfused. So again, this is small numbers when you think about it. We may give several units of platelets if their platelet level is very low. So before we transfuse any type of blood product to your client, we need to make sure they're compatible with that type of product. Testing is performed to make sure the client is receiving the right blood. There are antibodies to the red cell antigens in the donor unit, and you need to make sure those are compatible again with your client. It is required for all red cell transfusions, and it must match to ensure that there are no reactions when this blood is transfused and to prevent errors. A type and cross match is something that is done frequently on a client that we're anticipating we will be giving blood. Type means your client. It's the red cell type, the rhesus factor, and rhesus is R-H-E-S-U-S, rhesus factor, and an antibody screen. So they'll take a blood tube and do a cross match. And then what is a cross match? A cross match is the client serum and the donor cells are combined. And they are observing in the lab for agglutination or to see if the blood clumps. Obviously, if the blood clumps, we are going to have a reaction and we would not give that blood to our client. When you get a type and cross match, it's valid for 3 days after the blood sample is drawn because the client may develop new red cell antibodies. So that's important to know too, because if you have blood drawn or a type and cross drawn at the beginning of someone's stay in the hospital and it's a week later and suddenly we need to transfuse blood, they need to do a new type and cross match to ensure the best fit and they'll get the correct blood. So just so you know, it's every 3 days they need a new type and cross match. So patient teaching for blood transfusions. There is a patient's guide to blood transfusion, like leaflet that you can give your clients that can talk about transfusions, but it is very important that you get a written consent to give blood. Okay, this is done like any other consent. You need to make sure the client is alert and oriented and able to sign for him or herself, or you do need to find out who their durable power of attorney for healthcare is. In an emergency type of situation, one of the docs can actually override and sign that, but usually we do get written consent, and that is the norm, so just always expect to get a written consent before you transfuse the blood. So you need to inform your client to report any adverse effects and symptoms. Usually what I'll do is I will just tell that client that if they feel any different at all while this blood is going in them, to please let me know right away. I try not to scare the client because somebody who has never received blood before can be quite intimidated by the fact that they are going to get blood transfused. So again, I'll make sure they have the call out and reach. And we're usually in there for the first, like 10, 15 minutes anyways when a unit of blood is transfusing. So most of the time you will see reactions immediately. But if not, I just tell them, to please let me know if they feel anything different. So again, try not to scare them. There's a blood transfusion check. Okay, so one, you want to recheck the physician's order. Make sure that we're transfusing the correct type of blood that was ordered. And correct type of blood, I mean packed red blood cells, FFP, platelets. You need to know, or even whole blood. You just need to make sure you're transfusing the right type of blood product. You need to follow the hospital procedure for blood product administration. Okay, it is pretty universal across the board, but every hospital has their own policy written up on transfusing blood. So in the lab and at the bedside, both staff members will verify the client and unit number with the transfusion report, and then you will document it on the transfusion report form and the blood administration power form. So we can actually send in the ED an EMT to go pick up blood in the lab, or you as the RN can go, but many times we're busy and we will ask them to go, please pick up the blood. So if you have an opportunity to do this and you're on, on the med-surg clinical, go and do it just so you can see what the process is. So you go down to lab and then you go to the blood bank and you tell them what client you need to transfuse blood on. And then right there, they will verify the correct client, the correct unit and blood type number, and they do all of that as a first check right there. Now, because they are not administering the blood to the client at that time, that is why we can have like an EMT or an ACT pick the blood up from the blood bank. Once you get it to the bedside, you must have 2 RNs to verify that. And then you would do the same thing. You're looking at the client's name band, and you're making sure it's got the correct medical record number, and then you'll have a blood bank band also, and on it you will check for the blood type, and then the unit number will be on the blood. So we just need to make sure everything is in check. So when you transfuse blood, the equipment that you need, just remember, you always need to wear gloves to prevent any blood-borne illnesses. This blood is tested very carefully to ensure that there aren't any kind of diseases that could be passed along, but for your own safety, always wear gloves to prevent any blood-borne illness. We prefer an 18 gauge IV, just because usually the blood will flow in without any difficulty. But again, a 20 gauge can usually be used if it's in a good vein. You also need blood Y tubing with normal saline and blood. The blood tubing is in a Y because what you would do is you would hang a bag of normal saline and spike it on one end. You would prime your entire tubing, and then you would hook the blood up to the other port on there, and then that would go through a filter. You must have a filter for the blood, and that would be infused into your client. The filter does stop any clots from entering the client, so that's why it's important you always use blood tubing if you're going to transfuse blood. And again, you can tell that it's blood tubing because if you look at this top picture here, you can see that there are 2 separate spikes for 2 bags. And then you've got your clamp on both sides. So again, one is normal saline and the other one is your blood product. Again, prime the tubing and filter with normal saline, and then you can invert the tubing where the filter is to suspend any red blood cells. So what happens is sometimes when you are priming your tubing and you're just letting gravity go through, when it goes through some sort of filter or something, you might not get all of the air bubbles out and it might not totally prime it. So the way you can avoid this is if you just invert it, just turn that part of the tubing upside down, so that way the pressure and the gravity will kind of make sure that that whole filter is filled, with normal saline when you're priming it. Again, we're doing this because we want to catch any debris or clots. And also just know we always hang normal saline with blood. D5W will lyse red blood cells. It's L-Y-S-E, which means that it will kind of adhere to it and it'll make it sticky, and that is a no-no. So never D5W. And then LR, your lactated ringers, contains calcium, and that will trigger clotting. So again, the only type of infusion that you attach to this is a normal saline bag. Okay, so assessment. You always take a first set of vital signs. And this is initial. This is before the blood is infusing into your client, and it is a full set. So you're going to do your temperature, which is very important, pulse, respirations, and blood pressure. You want to inform your client to let you know if they have any back or flank pain, if they start getting a rash or itching or shortness of breath. So again, vital signs at baseline you must have, and then 15 minutes after. So what I usually do is I'll get my initial set of vitals before right before I know the blood is coming up, because once the blood is there, I need to get another RN to come in there, and I don't want to hold him or her up because they have their own client assignment. So I will get a baseline set of vitals, and if it's within like 15 minutes, you're okay. It doesn't have to be right that instant, but we need a current set. So get your baseline set of vitals, and then have the other RN come in. You confirm the blood against the patient, against the orders with the other nurse, and then they leave. And at that point, I spike the blood, I start the transfusion, and as I'm kind of filling out the form the blood transfusion form and stuff, before you know it, 15 minutes is really gone. This is a time where I can, sometimes have small talk with the client a little bit, but I usually like to stay in there that initial 15 minutes because, again, if they're going to have any type of reaction, most of the time it's sooner than later. So you get that 15-minute vital signs, and then you're going to get one 30 minutes after that. And then after that, it's every hour. And then post 1 hour. Okay, so I don't know this is if it's confusing, but it's vital signs at baseline, then in 15 minutes, and then a half hour after that, and then hourly after that until it's done, and they need a set of vital signs 1 hour post transfusion. Usually a unit of blood will go over a couple hours. So really, if you think about it, you've got your baseline vitals, you've got 15 minutes, then you've got 30 minutes after that, and then an hour after that, so you're doing one set there. And then usually when it completes, I'll grab another set, and then you've got your 1 hour post. So that's just kind of rule of thumb. And this would be on your Cerner documentation for blood transfusion. There will be spots for you to put in each set of vital signs, so it helps guide you too. So when you're going to administer blood, it is initially administered very slowly for this first 15 minutes. Okay, unless this is some sort of emergency situation, I'm going to just have it going pretty slow. You're going to go and have this go through the pump. So there is no set rate on this, but slow. If you're thinking you're trying to get a 350 ml bag over 2 hours, that's about 175 mLs an hour. Well, I don't want to do that initially. So I'll probably do like 50 mLs an hour just for the first 15 minutes. And then once I see that the client is tolerating it, I'll bump it up to that 175 and transfuse the rest of that blood. You want to make sure that when you hang that blood that it's still cool. Okay, blood is refrigerated in the blood bank. You don't want to warm it above 38 degrees because you'll get hemolysis if you do. And then another thing you want to know, you never ever add any medications directly to that blood. Okay, that must be done through a separate IV, or you must wait, or you must stop the blood and give the med with a good flush before and after. But usually you'll kind of know what your plan is, so never add medications directly to when you're getting blood. And you need to infuse a unit of blood within 4 hours. It can't take any longer to infuse each unit. Like I said, most of the time we infuse a unit of blood over 2 hours, but sometimes the docs will write to infuse it over 3 or 4 hours if they're worried about someone that has a little fluid overload, possibly, or a risk of this. But just know, by the time you pick up that blood at the blood bank, you have 4 hours to get that blood in. Another thing to know, you don't want to have somebody go and pick up blood at the blood bank until you are pretty ready to go. So make sure you have your IV in. Make sure you've got your blood tubing in there. You already have your saline priming the tubing. It's good to go because you must start that blood within 30 minutes from the lab to the floor. Okay, if not, for some reason, let's say the client goes off for a test or something, you need to return that to the blood bank and then do the process all over again. Okay, so don't hold on to it. Please don't put it in the refrigerator somewhere on the floor to keep it cool. If you're unable to start that transfusion for any reason, any more than 30 minutes from when that blood was picked up, we must bring it back to the blood bank. So problems with infusion or problems with rate of infusion, the filters can clog with coagulated proteins and cellular debris. So if you backfill the red blood cell unit with saline to decrease viscosity, that will help with this. So what does that mean? That means, again, you're priming with your normal saline through the tubing and through the filter first, because that will help prime it to where the blood will transfer easily through that filter. You want to dispose of the blood bag with attached unit record and red flags. You need to make sure that the client identifiers are off. So if the client's name on any part, we do need to actually get that part off and shred it. But the blood bag, and then actually the tubing, once you're done using it, would all go into a red bag. So there are different types of transfusion reactions that a client may have. Mild reactions to anaphylaxis to circulatory overload. I mean, it can be anything. An overview of allergic reactions, there's many different terms for the same reaction. At the bedside, you may many times be unable to determine between the specific types or causes, but lab would tell you later. Okay, so a mild allergic reaction is caused by a reaction to the plasma proteins in the blood or the component unit that the client is getting. This is the most common transfusion reaction. It's about 1 to 5% of clients that receive blood could get a mild allergic reaction. And mild is mild, thankfully. It's mild and generally easy to treat. Signs and symptoms that you will see on a client, you may see hives, you may see pruritus, which can be kind of vague, or like the skin rash, that you see here on this client. The onset is during a transfusion to 1 hour post-transfusion. So if you're going to see a reaction, many times it'll usually be in the first 15 minutes, but it could go all the way into 1 hour after the transfusion has been completed. So nursing interventions, prevention is what you will see on the floor many times. What that is the doctor will actually pre-medicate the client with Tylenol and Benadryl before the transfusion is started. So that's, they try to avoid this mild allergic reaction anyways. They may also order an antihistamine for the client to get if they have got this allergic reaction already going on. And if it's a mild allergic reaction, you want to stop, assess it, and you could restart it slowly just to make sure it's not getting any worse. But you do want to make sure, if they hadn't received these medications beforehand, call the doc. The doc will give you an order to give the Tylenol and Benadryl and maybe an antihistamine. And then after you give that, you could restart it slowly. You do want to look out if your client has a fever or pulmonary symptoms. Definitely let your doc know, because they may tell you just to go and stop the transfusion. So acute hemolytic reactions, this is caused usually when there's a blood type error. There is ABO and RH errors, or incompatible fluids, like if you hung a blood transfusion with the D5W or LR, something like that could cause an acute hemolytic reaction. There's a reaction to antigens or antibodies. It triggers a cascade of chemical responses, and once it starts, it will continue unless stopped immediately. Signs and symptoms that you will see if somebody has an acute hemolytic reaction. Many times your client will tell you they just have a sense of doom. They're like, there's just something not right. I just don't feel good. Take your client seriously, because that may be the first sign that they are giving you. They may complain of severe low back pain, in the kidney area or flank pain, okay, or even chest pain. But again, be very suspicious if you hear someone complaining of kidney or flank pain or chest pain when this blood is being transfused. They may have dyspnea or bronchospasm. They may have a fever. So again, this is very important because you got those baseline vitals. If you see some sort of reaction like this, recheck their vital signs. It could be 1 degree Celsius or 2 degrees Fahrenheit above their baseline. So it's not a huge jump, but still it's significant enough if they're complaining of other things that this could be an acute hemolytic reaction. If this is not resolved, your client could go in shock. They can have severe hypotension and, in worst case, cardiac arrest. Okay, so obviously we want to avoid this at all costs, but that would be done by you just being diligent, assessing your patient and listening to what your patient is telling you. The onset, again, is anytime during the transfusion to 2 hours after for an acute hemolytic reaction. And this, again, is usually sooner than later. This picture here is somebody that is in anaphylaxis. So they show, he has a loss of consciousness. He broke out in hives. His tongue has swollen up. so bad that he cannot swallow, and then the throat tissues swell up also. So this again is a medical emergency. The transfusion must be stopped immediately, and you need to get, actually I would call rapid response, because they will get things done quicker than you waiting for a doctor to call back on the floor. This here is a picture just of the anaphylactic reactions. So this is showing if you have a donor type A and a recipient type B. They could have clumping of the donor cells, so the donor cells could burst, and if they do, then when they go through their kidneys, they can cause kidney damage, or they can cause a blockage, which will reduce your blood supply. Okay, so again, an anaphylactic reaction is never good, and again, it's never good with a blood transfusion either. So nursing interventions, what do we do if we see a transfusion reaction? For all reactions, you want to stop the transfusion, okay? Always. You may end up restarting it if it's a mild allergic reaction and you pre-medicated, but the first thing you want to do is stop it, okay? Always, always stop. Then you want to hang new tubing with normal saline TKO. Okay, if you look in that picture there, they've got the white tubing with the blood and the normal saline. But the blood, if you look, is all the way down in the tubing to your client. So by the time you primed it with saline, you will be pushing all that other blood into your client. So you need to hang new tubing with normal saline if they are having a reaction. Closely monitor the client's vital signs and symptoms. Perform a clerical check. So recheck, did I have the correct blood? Is it the correct identifiers on there? Because sometimes human error can be a cause of this. And then notify the physician. Notify signs and symptoms, vital sign changes, and then your physician may order oxygen, IV fluids, again that normal saline, and then medications that you may be giving is epinephrine, antihistamines, and an antipyretic. And then if your client is in shock, we're going to treat for shock also. So if you look at this little picture that we have here for a blood transfusion reaction, you see the blood is going through. The nurse there should be stopping it immediately. They're telling someone to call for help, and they're notifying the doctor. The blood tubing, whenever you have any type of reaction where we're stopping the blood entirely and not restarting it, the blood and the tubing are disconnected and sent to the lab for evaluation. Okay, we don't just throw that in a red bag and throw it away. That needs to go back because we need to find out why the client had this type of reaction. Okay, circulatory overload, also known as hypervolemia, may lead to heart failure. What causes this is the inability to handle increased circulating blood volume. It's more common in pediatric clients and your geriatric clients. So again, your younger and older clients have a higher risk of having circulatory overload. And somebody that has a pre-existing cardiopulmonary disease. Symptoms. Okay, this one I want you always to be on alert for, because if you see a client that suddenly has restlessness, you need to try to figure out why, because somebody doesn't just become restless for no reason usually, and they may not know what's going on. But if you see someone with restlessness and dyspnea, these are your cardinal signs for circulatory overload. There usually is no fever with circulatory overload because they're not having a reaction to the blood per se, they're having a reaction to the volume that has gone into them. You're also going to see an increase in respiratory rate. You're going to see their heart rate go up and their blood pressure go up. If you look in this picture here, he has a positive JVD. So you will see that jugular vein distension many times on somebody in circulatory overload also. And the onset is during the transfusion or up to 24 hours following. So that's a long time. So it's important that you do, teach your client to look out for these signs or symptoms, especially if you work like in an outpatient blood transfusion type center where they get blood and they go home after. So early detection for your nursing interventions is key. You need to monitor, you want to listen to lung sounds, and it's important for you to assess breath sounds before the transfusion so you have a baseline. You may hear crackles or rails in fluid overload. But what if they had some sort of respiratory thing going on before and you weren't sure? So that's why it's important you listen to their lungs before to get a baseline. But generally with circulatory overload, you'll hear rails or crackles. Stop the transfusion if this is occurring while the transfusion is going. You may receive an order to restart the transfusion at a slower rate. Okay, but that's up to the physician to order that. You put normal saline, TKO. That client needs to go in a high Fowler's position. They're probably almost going to be tripoding if they're in true circulatory overload anyway, so they are going to be sitting up. But if not, put them in that high Fowler's position. Notify the physician. They may order oxygen. You may get diuretics to get some of that fluid off, and they may give morphine to help calm the client and ease with any pain. So just, keep in mind, circulatory overload is a medical emergency, but if you notice it earlier, you can definitely help the client going through some of these more extreme things. Okay, so moving on to anemias. We have acute or chronic anemia. Acute anemia, again, is where you have blood loss that happens suddenly. It does usually produce some sort of shock. Usually it's hypovolemic shock because, again, they're losing volume. You may have a chronic anemia, which is a slow loss of blood with compensation. So your body can compensate for that blood loss because it is losing it slowly over time until eventually it just doesn't have enough blood in there to supply oxygen to the organs to where you'll start seeing more signs and symptoms of being tired, maybe not feeling well, and this is where we start to investigate by drawing labs on someone. So signs and symptoms, especially in acute anemia, you will see increased cardiac output, and eventually you may see tachycardia, tachypnea, hypoxia, and then pallor, fatigue, and weakness. You can see over on this picture there are many other signs and symptoms that you may see on somebody. They may just be complaining of muscular weakness, because again, they don't have enough blood circulating to supply oxygen to all the tissues and organs that is needed. So nursing interventions, the main thing, you need to find a cause and treat it. What's causing that anemia? Again, if it's an acute one, it's obviously a little bit more emergent because it's acute. And something drastic is happening on, and that client could be possibly going into shock. Or even if it's a chronic anemia, we still need to find out why, what is causing this. It could be, again, bleeding that is causing this. It could be diet. Maybe they're not producing enough iron-enriched foods or eating enough iron-enriched foods that can help, with blood production. Or it could be a medication that's causing anemia. If a client has hypoxia, we need to make sure they are on some oxygen. Because again, that will help them as far as make them more comfortable and get more oxygen to their body that needs it. You also need, especially this is for chronic, pace the activities. Okay, if a client has chronic anemia, they're going to be complaining of being tired all the time and not having a lot of energy. So it's important that they learn how to pace out their activities so that they can tolerate this a little easier. So different types of anemia that we're going to go over include iron deficient anemia, pernicious anemia, hemolytic anemia, and aplastic anemia. There are also many other different types of anemias, but these, I think, if you focus on these, you'll have a good understanding about anemia in general. So iron deficient anemia Causes can be lack of eating enough iron-enriched food, so dietary inadequacy. Another cause of iron-deficient anemia is blood loss, and it could be an acute or chronic is your most common cause for iron deficiency anemias. A decrease in GI absorption. You may have someone that has a lot of diarrhea, malabsorption syndrome, stuff like that, to where they are not able to absorb iron-enriched food. Things are passing straight through them. Risk factors include females, usually between the ages of 15 to 35, that are menstruating. If they have bad menstrual cycles, they could actually have iron deficiency anemia. Your elderly could. Vegetarians are at a risk. IV therapy more than 10 days can cause iron deficiency anemia. And then GI absorption problems like chronic diarrhea can cause this type of anemia. Signs and symptoms can range from asymptomatic, which is the most common, to spoon-shaped nails. You see that picture up there? That's not normal to see somebody's nails like that. So if you see somebody that has spoon-shaped nails, they need to get their blood levels checked, because more likely they have iron deficiency anemia. And then first signs and symptoms with iron deficiency anemia are weakness and fatigue. Okay, that's important to know, because how many things cause weakness and fatigue on a client? So many. But just know those are your first signs and symptoms that you will usually see. When we draw labs, you will usually see a decreased hemoglobin and hematocrit and red blood cells. And then the red blood cells, there's different types of microcytic red blood cells that are abnormally small when you do this. You'll see a decrease in your MCV, your mean cell volume, a decrease in your mean cell hemoglobin concentration, which is MCHC. But again, really, the microcytic red blood cells are abnormally small, and that again is a red flag that somebody has iron deficiency anemia. You'll also see a decrease in the iron level, decrease in the ferritin level, which would usually be less than 10. Check a hemocult. Make sure they don't have blood in their stool. Many times a client doesn't realize that they have blood in their stool because it's mixed in the stool and it's not so obvious like an acute lower GI bleed. So you may need to check the hemocult to make sure that there isn't any blood in the stool. And if you don't know what hemocult is, it's just this little testing pad that we have to where you would take like one of the popsicle stick types that they have. You would take some of their stool, just a tiny bit, and smear it on there, and then you would put this agent, drop this liquid agent on it. If it turns blue, it means that there's blood in it. Okay, so you'll see many times we'll check hemocult in the ED for acute stuff there you physically can't see if it's blood. So nursing interventions, treat the underlying cause. We need to check for bleeding, make sure they've got make sure that if there's any medications that they're taking that we're compensating for that, and then their diet. The best source of iron, as you can see on here, is lean red meat. It can also be found in chicken, turkey, eggs, and cereal. So remember, I said someone that's at risk for iron deficiency anemia is a vegetarian. So many of that stuff, if they do not consume, they could be iron deficient. So increase iron in diet. Again, you've got fish, red meat, raisins, organ meats, green vegetables, and beans also have iron in it. So those are some suggestions that you can give to your client. Medications, ferrous sulfate. Many of you have given ferrous sulfate with me. Usually it's an oral pill, and we give it with meals to decrease GI irritation. If it is a liquid ferrous sulfate, give it to your client with a straw to avoid staining the teeth. And then if it's an IM injection, you don't want to massage it because you just don't want that to be brought up to the top of the skin, because that could be just very irritating to the skin. So If somebody has an acute iron deficient anemia, they need frequent rest periods. Okay, you may want a place near the nurse's station if the anemia is severe, because they could have a decreased oxygenation to the brain that can make them confused, which again is a safety issue. You know, and again, the safety is huge when we need to plan nursing interventions for a client. So frequent rest periods, and put them closer to a nurse's station so that way they can be monitored closely, and if they start getting more confused, you know, we can catch this, you know, and hopefully avoid some sort of fall or something that could harm them. You need to decrease tanatics, which is your tea and coffee, because that will actually decrease iron absorption. You know, so that can be tricky, you know, for somebody that likes to have a lot of coffee or tea. So, you know, you just may need to get a little creative with them, or just kind of explain to them that that could help if they stay and they might stay away from the tea and coffee so much, they could have an increase in their iron absorption. Okay, so pernicious anemia, we're moving on to. This is a lack of vitamin B12. Okay, this is due to a lack of vitamin B12 in your diet. There is something called an intrinsic factor, which is needed to absorb B12 into food. It's secreted in the stomach. And then absorption. It's decreased production of hydrochloric acid, which is needed for B12 absorption. Or you could have H. pylori infection, which damages the mucosa, which diminishes absorption of B12. So there are different reasons, you know, that can cause pernicious anemia. Risk factors include if you're over 50, gastric surgeries or disorders that affect absorption. So if somebody had a gastric bypass surgery, have Crohn's or an inflammatory bowel disease, or gastric atrophy, you know, these types of things could cause the absorption that can cause pernicious anemia. And then strict vegans are they're also at a risk for pernicious anemia. So labs, you're going to see a decrease in your B12. The red blood cells, again, you're going to see increase your MCVs. There usually is a normal MCHC in this type of situation. And then signs and symptoms of anemia that you will see include fatigue, depression. They may have short-term memory losses. They may have glossitis, which is a beefy red tongue. And there's a picture of one up here on your slide. And there may be actually paresthesia, which is nerve function due to loss of B12. So they may be having some difficulties with that also. Okay, so for pernicious anemia, some nursing interventions is you want to encourage a B12 diet. If you see on this chart here, those B vitamins are mostly in meats, cheese, eggs, and seafood. So again, if you have a strict vegan, you know, they are going to possibly be at a risk for pernicious anemia. They may need vitamin B12 IM for life. If the absorption is permanently compromised, then their intrinsic factor is not working, oral medications won't work, they need to get an IM injection of B12 for life. Symptoms of pernicious anemia get better after several days of B12 treatment. If you are having an acute phase of pernicious anemia going on, you also want to have them on bed rest. And then mouth care, make sure you use soft toothbrushes and no mouthwashes. You know, so it's important that you are diligent with that also in the acute phase of pernicious anemia. Hemolytic anemia, the cause of that, there could be an inadequate number of circulating red blood cells due to premature destruction of red blood cells. So it can be an acquired type of cause, like a hemolytic transfusion reaction or an autoimmune reaction, or it can be inherited, like a sickle cell disease can cause hemolytic anemia. Clinical manifestations. The severity of the disease depends on degree of how bad hemolysis and anemia are working. So hemolysis and anemia in compensatory erythropoiesis, which means how well is the bone marrow producing red blood cells. You know, that is a huge cause in hemolytic anemia if that is not working correctly. Signs that you could see also include an enlarged and tender spleen due to blood cell removal and antibody production, and an enlarged liver. So your client may have jaundice and dark urine. So dark urine is like tea colored. So if you see tea colored, think something may be going on with their liver. And this is due to the inability to excrete bilirubin as fast as red blood cells are destroyed. So collaborative care and nursing interventions is specific to the disease process which is causing the hemolysis. So we need to find out what's causing this hemolysis and fix it. It may be removal of the causative agent, like if it was a drug or blood transfusion reaction, we need to stop that. Medications that we will give include folic acid, iron replacement. They may give corticosteroids depending on the cause, and immunosuppressants, again, depending on the cause. Worst case, they could do a splenectomy. You can live without your spleen. The function overlaps with other organs, but you will have an increased risk of infection if your spleen is removed. The spleen's main functions break down hemoglobin, destroy old or defective red blood cells, and store platelets not circulating. So again, you do have a higher risk for infection because of those main functions. They may do a plasma exchange therapy where they remove the antibiotics, and this is similar to a dialysis treatment on how they would do something like that for a hemolytic anemia. Okay, aplastic anemia. The cause of this is damage to stem cells or bone marrow environment from drugs. So they could be on chemotherapy or antibiotics that could cause an aplastic anemia, some sort of chemical ingestion, radiation, an infection. And unfortunately, about 50% of them, it's unknown why they have aplastic anemia. Signs and symptoms with aplastic anemia include anemia. So you're going to see low red blood cells. You're going to see an increase in bleeding. They're going to have low platelets and thrombocytopenia. You will see infections, again, because of low white blood cells, which is also leukopenia. And then pancytopenia, that's up on your slide here. It's a decrease in the number of red blood cells, white blood cells, and platelets. The bone marrow is not producing any of these. So if you have somebody that has pancytopenia, this can be a pretty sick person here because, again, it's got a decreased production of red blood cells, white blood cells, and platelets. To diagnose aplastic anemia is a bone marrow biopsy. This is usually done in the iliac crest, as you can see in that photo down on the bottom left. This is an uncomfortable procedure, so you do need to let your clients know, that they will be feeling some pressure and possibly some pain, but they will try to numb the area and keep them as comfortable as possible. But it is important to do this to diagnose them correctly. So aplastic anemia, collaborative care and nursing interventions include removing the cause if possible. Some temporary things that you may do for them is they may be on bed rest. They may be receiving oxygen. They may be receiving some sort of whole blood transfusion. Again, whole blood, this includes all types of cells, your red blood cells, white blood cells, platelets. They may need all of those transfusions. Medications, they may be getting antibiotics due to secondary infections and immunosuppressants also. They may have a splenectomy. This is still a little controversial, but the CDC does say it's safe and that will increase your blood cells immediately. You need to provide safety to your clients due to low platelets and red blood cells, and then monitor for bleedings due to loss of platelets. So make sure you try to avoid any unnecessary IM injections or sub-Q injections or razors with these clients. You also want to make sure that they may be on reverse isolation if their white blood cells are low, to avoid infections and to protect your client. Again, that reverse isolation is so important if they have a low white blood cell count to avoid infections. They may do a bone marrow transplant. There's something called a hematopoietic stem cell transplantation, and that's here on your slide. And it's a plasma infusion, so it's kind of cool. The stem cells are peripherally from the donor now, and we'll go more in depth in third semester with that. But the donor, they get the bone marrow from, and they do the bone marrow transplant through a transfusion, so the client can get that. And then one last thing is, once the client is DC'd home with someone that had aplastic anemia, you need to teach them to avoid alcohol, pace their activities, and eat a balanced diet to manufacture blood cells. So it's important that they understand, the importance of all of these. Again, it's avoid alcohol, pace activities, and eat a balanced diet to manufacture blood cells. Okay, that's all I got for you this week. Please let me know if you have any questions, and I will see you soon. Thank you.